Okay, well, it's clicked over to 203 on my computer, so I think we might make a start. So for those of you who don't know, I'm Jane Morton, I'm from VADA. There's Naomi Carter from VADA. I think quite a few of you have been on our first, well, certainly at least one of the prior webinars. So anyway, and we have some guest speakers for you today who Naomi will introduce to you in a minute. So I would just like to welcome you all and start by acknowledging the traditional owners of the lands that we're meeting on, and pay my respects to any elders past, present and emerging. And as I said, we've got a very, very busy agenda today talking about family violence. So I will hand you back to Naomi and she'll do a little bit of housekeeping with polls for you.
Hi, cool. Thanks, Jane. I'm not going to introduce our guest today other than saying it's Sue George and Stephen Hurd, who are both specialist family violence advisors. I think they're much better placed to introduce themselves. They probably know who they are and what they do better than me. But before we hand over, I would like to do just a very quick poll to get a sense of your understanding and confidence of working with family violence in an AOD context. So I'm just going to pop that up now. If you could fill that out, that would be fantastic. Wow, cool. That was very quick. Okay, so I'm going to share that with everyone so you can see. You can see you're all feeling pretty okay, but want to know more, which is a really great space to be. So I have no doubt in my mind that that Sue and Stephen will be able to help with that. So I'm going to share screen now, share PowerPoint, and hand over I think to you, Steve, first up, isn't it?
Yeah, that's right. Thanks, Naomi.
Beautiful.
Great. Yeah, well, good afternoon, everybody. Yeah, it's good to see that poll there. Really sitting in that mid area of family violence. And I guess that's how we want to start this as well, with some understanding what family violence was about. But we want to move into other nuanced areas as we go along. Just by way of introductions, a little bit more.
Sorry. I wasn't able to, give me just a moment. Okay, I wasn't able to change slides, but I think now I will be able to. Thank you.
Great. Yeah, so my name's Steve Hurd. I'm a specialist family violence advisor in the AOD area at Turning Point. And I guess my background over the last 10 years or so is working with perpetrators in men's behaviour change. So that's my main focus of experience, and I've been in the AOD sector for coming up to about 2 years now. Not a clinical role, but a capability building role, working with clinicians, working with teams, working with organisations to help move family violence and MARAM type initiatives into the AOD space. And then just over to you, Sue, then, just for your intro.
Yeah, thanks, Steve. I'm also a specialist family violence advisor in the AOD sector. I've been here about the same amount of time, coming up for 2 years. But also, just to give a brief outline of my background, I've primarily worked with family violence, with victim survivors, and I've done counselling, family violence counselling, case management, and also done group work with victim survivors. So that's my area, and recently the last 2 years with Odyssey. But the other area that I've worked a lot in the homeless area, so that also combines that intersection between family violence and AOD. So that just I bring that flavour in as well. Thanks, Steve.
Yeah, thanks, Sue. So our agenda for today is just to discuss what we're going to be covering. So I'll just run through some family violence essentials. It won't be 101, but I'll be covering the top issues or the top points that we feel are important. Sue will then be talking on victim survivors in relation to substance use. And then I'll be talking more on perpetrators, probably the recognition, identification and some elements of engagement. As is with family violence conversations, we do use terms like victim, survivor and perpetrator. We do also acknowledge that family violence is gendered, where majority of victims are women, majority of perpetrators are male. But we also know that family violence occurs in a whole lot of different relational contexts, not just intimate partner violence, though most of the research is in that area. It also occurs with adolescent violence at the home, adult child who might have moved back and impacting their parents, elder abuse, obviously, sibling violence. Violence occurs in same-sex relationships. It's really that relational topic. And then in Indigenous communities, of course, the violence is different again. It's a community-based type behaviour. We will be talking around, like I said, victim survivors and perpetrators. I'll probably use words like her and he, just really acknowledging where a lot of the where violence can be. We also ask you to use a bit of self-care. Topics like these can raise issues for ourselves, not just for our clients, but also we might be impacted by it directly or indirectly. So we're starting from looking at a few resources that we acknowledge already exist that really help form the base of family violence and AOD work. There are 3 webinars I'd like to draw your attention to. One from 2018 that talks about identifying and responding to family violence in AOD. The second one is around substance use, in particular substance use coercion, that Sue and I did with Mariah from VADA in 2019. And really recently, Ada Conroy from Women's Health in the North put out a really nice webinar responding to family violence during COVID. And she raises some really nice points and even develops a power and control wheel that makes behaviours around COVID really quite visible. And there are links there to source them. So we sort of take off from that knowledge. The other key resource I want to point out are the Marron practice guides. They've been out since July of last year, and they really do step out different responsibilities and roles for different workers in different contexts. So we'll go straight to a breakout question. So in pairs, I think it is. You just want to get a handle on what do you think are the greatest challenges in working with family violence within an AOD setting? What are some of the key issues around family violence and AOD? Okay, welcome back. Welcome back. Just wondering if 2 or 3 of you would like to just sort of say what you came up with as far as the basic challenges, probably the first thoughts are the best. Would anyone like to signal what they'd like to add to that?
So for our group, we discussed the fact that sometimes the challenge can be that the client might be feeling that they're presenting in an AOD service and not really be expecting to be answering questions that might be alluding to some form of family violence. Yeah. And so it's that delicate balance of keeping that client engaged, keeping an ear out for the risk, whilst but at the same time trying to maintain the engagement.
Yeah, that's great, Elaine. Yeah, perfect. Anyone else? Okay. Well, I guess two of the challenges that Sue and I find, one for me is around identifying perpetrators and keeping them visible. And Sue, what was your great challenge?
I think it was a bit the same, how to respectfully engage, but without colluding and maintaining that engagement. So how to do that respectfully. And I think that is, a really big task to do and really needs some ongoing work, and we'll develop those skills. So, and that way keeping the perpetrator in view while being respectful to that work with them. Yeah,
thanks, Sue. Okay, so what we'll do, we'll just touch off on some family violence essentials. So back to the slides. And some of this information you probably know, but I'd just like to sort of encapsulate it in a very, very quick, dense kind of form. The two of the important tools, I guess, that are becoming more popular with family violence is the parent control wheel, which really does look at different behaviours that victims can be subject to. And the thing I like about the parent control wheel, I really like, is that it is developed from the narratives of female victims and how they experience what they experience in a home environment that you'd call family violence. It was done in the 80s, as you probably know, and with some relief, a lot of these behaviours now are part of our legislation. The second tool are the red flags, which are those elements of a relationship that you'll pick up on in narratives around a person's experience as to what's really going on in family violence, such as experiencing controlling behaviours or threats to kill, being pregnant, or recently finishing a relationship, are all risk factors around family violence. Just move on. Now, though, the risk factors have been really broadened in the Maram world with a lot of evidence base around various factors that really do raise the risk of a victim survivor being killed or nearly killed by a current or former partner. And I've highlighted those ones involved. You also notice on the left-hand side a range of perpetrator behaviours that are probably the real focus of these risk factors that we try and keep in mind to really try and paint a picture of what's going on. Importantly, with Maram 2 on the right-hand side, are behaviours impacting children, and they're becoming a really strong focus of our attention for their experience of violence in the home. And probably the third of these essential issues is what substance use coercion is. And up the top, I've got a definition where abusive tactics are targeted towards a partner's substance use as part of a broader pattern of abuse and control. So given the idea of a victim using substances, that can be used against them by a perpetrator in a whole variety of ways. And the grid down below, I haven't got quite time to go through it in detail. Perhaps you can look up the substance use coercion webinar. But in the top right-hand corner, where we have the intersection of victim survivor substance use, so acknowledging that the victim does use substances, but in that top row is associated with perpetrator strategies, is that a common narrative around substance use coercion is that a victim will be encouraged to use substances against their will. The substances will be controlled for them, what they have, the quality of it, how often, that kind of thing. Maybe even control the administration, in other words, being injected themselves, if that's the mode. The perpetrator can interfere with their treatment if they go and seek help. What opportunities do they have to get that help? Or even when they do get treatment, how the recovery in that process is impacted. And the last major feature is using children as weapons. So demeaning the parent or the non-offending parent with statutory bodies like child protection to say, don't call them, otherwise I'm just going to tell them what a useless parent you are. Now neglectful. So they're the essential features. I just want to get some more feedback around in pairs again, a quick breakout. So do those features of the parent control wheel, the risk factors and substance use coercion play a part in your work? And if they do, how do they?
Have we got everyone know me? Okay. Well, we don't have time. Thanks for doing that, but we don't have time to hear back from everyone. But I'm just wondering, because these might be concepts that you're already using, just some feedback from a few people about that. And I know this is a hard space to do it on Zoom, but if you can just, if there was anything that was outstanding for you, if we can just unmute yourself and tell us.
I think I was in breakout group 4, and so the other 3 participants are all very new to AOD. So it's really great that they're here and on board. So it's like, oh, what can I offer them? But it was like going back to the resources that you've already showed us, like
Yeah.
in relation to the red flags and the high risks. So that's your basic go-to
Yeah.
work when it comes to substance use and family violence. So,
Yeah.
you know, all of our clinicians have that
Okay.
poster on their desk. So it's well embedded in their mind. So if they're hearing of these sorts of things happening with their clients, it's a red flag that they need to gently explore more, do
Yeah.
an assessment, get a secondary consult to try and increase this person's safety.
Yeah.
In regards to substance use coercion, yes, working with women, it is alive and well. I don't do direct client work myself. Hearing about in supervision, we know that it happens a lot. So people with substance use disorders or dependence, their partners will be supplying it. Don't want to engage in family drug support. They're very happy to keep supplying their partner with substances. And my understanding is, and so with all these experts in the room, I'd love to hear more about this, but quite often perpetrators will use opiates, particularly if they've traumatised their partners, and it's a way of keeping them calm, keeping them quiet. So perhaps different substances are used for different reasons.
Yeah.
Yeah. So,
Thanks for that, Karen. And I think it's just a reminder, you know, because Steve spoke about them as family violence fundamentals, and certainly the wheel of power and control is a good thing to have up along with the red flags, because it really does highlight some of those strategies as well. And I think it's just a reflective thing to use as well. So thanks for doing that. I wanted to move on. We might go back to the PowerPoints now, Naomi, because we're a bit rushed for time. And I wanted to, following on from those family violence essentials, I wanted us to have a look at identifying substance use coercion, which is a really key part of family violence and how to identify family violence, because substance use coercion it identifies the substance use is related to living with fear, and fear is going to be a really good assessment for if there's family violence, isolation, entrapment, and experience of economic control. And certainly those 3 ones and are really escalated, certainly isolation and entrapment during the COVID-19, so to pay attention to that. Can be experiencing economic control, physical violence, sexual coercion. If you're listening and you're hearing about make-up sex, that can include sexual coercion. Being stalked, dealing with injury, related disability, chronic pain, interpersonal betrayal or trauma-related mental health system. And what I've done throughout this presentation is listed some examples of questions. Now they're just examples, and working with the client you will know what might be more appropriate questions, but they're just a bit of a guide. So you might ask questions, thanks Naomi. I wonder how using more than you want to might be related to living in constant fear of being told that you don't matter. Or I wonder how your struggle with overdose might be related to feeling trapped and seeing no way out. For some other examples of questions around can be, how does your partner treat you when you use substances? So these are questions around AOD use, but you're also talking about how the relationship impacts on substance use, and who decides how much you use and what you use. Also, you know, if someone else is injecting them, you know, who does that, and how do they know how much they're actually using? You can ask, like, what happens when you do not have substances in the house? And I think certainly with COVID-19, with the increase in alcohol use and the increase in cost of substances, that can be a really good question to assess what's happening in the relationship. Who's responsible for sourcing the substances? And what does your partner do if you say no? So all of the answers to these questions, which are really about substances, give you a lot of information about power and control and coercion in relationships. If we're looking at responding to disclosures, it's really important in how a practitioner responds. So it's important to validate her experience and acknowledge the impact on her and her children around family violence, and understanding that risk increases after disclosure, and that's also disclosure in actually speaking to a practitioner. So don't underestimate that will increase risk, and following up safety around that. Providing family violence information. I think a recent COVID strategy is to say that services aren't open, there's no one that can help you. So really having up-to-date information about that, because family violence services and police certainly are responding. Explore safety and wellbeing of the children. Address immediate and ongoing risks for safety, and work in partnership with survivors to develop a safety plan, because they're working with this 24/7 and they'll know what they've actually already tried and what's worked and what hasn't worked. And in Ada Conway's presentation, which Steve referred to, that's gone into a lot more detail. So the use of the family violence information sharing schemes and children information sharing schemes to enhance assessments and promote cross-sector responses, and also enhance that collaboration. And I think during COVID-19, there's more opportunities to do that, because most agencies are working with home. So this is a good opportunity to follow that up. If we're looking at, it can be important what you say as practitioners about family violence. And so you might make statements like, responding, sorry, I've got another thing coming up. Your partner might find other people to agree that your substance use gives them the right to control you. And this tactic can make you feel isolated and further their control over you. So you can talk about the isolation, and the COVID-19 can be a really good leverage into asking about isolation and what's happening in the relationship. And not necessarily talking about family violence, but certainly talking about isolation. Also statements such as, by undermining your credibility with other people, your partner makes it more difficult for you to get support, be believed, and trust your own perceptions. Good to point those things out. So you can ask questions such as, does your partner put you down or make you feel stupid in front of others? Or I wonder if your fear of losing custody of your children is related to being told you're a bad parent. And I think often it's a standard threat about making a notification to child protection for women to lose their children is the most serious thing that can happen to them, and increases further isolation. And I wanted to talk a little bit more about children, because children are often weaponised in family violence. So survivors might be, just keeping this in mind, victim survivors might be reluctant to engage in treatment, knowing that the perpetrator might use this against them in a custody battle. Because that's, and also with this isolation in the home and children being home and there being homeschooling, this can really increase that those issues about the threats towards a victim survivor about their parenting and ability to parent. So the stigma associated with substance use problems makes it feel less likely that survivors will be able to be seen or capable of parenting. And as I said, during this time of isolation, that can really be expanded and made bigger by the perpetrator. Perpetrators may accuse their partners of abandoning their children if they seek inpatient or residential treatment. And I know those services aren't as available now, but I think data is saying that there's more contact with perpetrators of survivors, more contact from intake with perpetrators of violence, and much less contact from victim survivors. So you can ask a question, maybe not in this time, but about any treatment. Are you concerned about the care of your children whilst you're in treatment? And also, under COVID, the safety in leaving children, it may be very unsafe to leave them. The perpetrator. I just wanted to finish off with this, because what we're looking at now is ways that the victim survivor is active in surviving. And within the context of coercive control and family violence, they are actively making efforts to survive. So really important to see these acts of resistance that victim survivors do. They take a range of strategies to attempt to successfully minimise the threat the perpetrator poses and helps them to survive the day. Victim survivors need to constantly assess their partner's mood and may find it necessary to cover up for their partner as part of their survival strategy. So it can be really important not to just say, oh, they're minimising and they don't understand. So it's important to find out what's happening behind that. Also, what appears to be dysfunctional may be an excellent survival strategy for the abused victim survivor. And I'll give an example from the overdose prevention program at Odyssey House, where a woman had overdosed and been taken to hospital. And when there was further inquiry, she had overdosed because this was the only way she saw of leaving a really severe family violence situation. She was fearful of calling the police because of previous charges and warrants out on her, and worried about the police finding drugs in the home. So the overdose was the only way for her to escape, because that meant that an ambulance would be called. And how this can be seen as a dysfunctional aspect to her treatment, her AOD treatment, because she'd taken another overdose. But she needed to get her act together. But it is her only way of keeping safe. And it means our interventions focus on the overdose rather than on the family violence, which has precipitated the overdose. So when victim survivors are encouraged to stop these behaviours that we may think are dysfunctional, they are in essence being asked to stop doing what may be keeping them alive. So it's really important to ask those questions about family violence. Other dysfunctional ways might be self-medication or a relapse. Directing the attention of the person using violence away from the children, and often might place the victim survivor in a much more greater risk in order to protect their children. And they may be fearful of the threats to involve child protection, but it might seem dysfunctional that the woman is placing herself in that position. Also, fighting back, running away, retreating within. Not talking to anyone may be her way of protecting herself from being exposed to her community, exposed in her workplace. And she may see this as protecting her family, and it's a way of her dealing with the shame. So what I've gone through is just really short summary of how this might be relevant in working with COVID-19. And as I say, it's a great reference that Ada Conway has done, and that you can, to watch that video, gives a lot more detail about victim survivors. So Steve will now speak about working with the perpetrators. Thanks, Steve.
Yeah, thanks, Sue, for that summary around the victim survivor experience in an AOD setting. So what I want to provide are some reflections of mine, essentially, of my work with men in men's behaviour change programs over the last several years, adding into the sort of the knowledge around how perpetrators can present and what strategies that you might invoke to identify that, and then what Maram sees us doing as clinicians in this new world where we are expected to start talking about family violence and respond to it. So I've listed out a few key ones there, and the first one is men who have attended programs generally have a victim stance. Victims of the current courts they're going through, of the police, of child protection, of their partner. And that victim stance is very much based on what's happening now for them, without much consideration with what's been happening for the last 12 months, 2 years, 5 years through their relationship. Very much what's happening now. And what that what the victim stance is inspired by is when their own personal entitlement to power or their own privilege is being challenged, and so out comes a victim type stand. Well, that's one of the ways it can materialise. Other things are around justifying, minimising, or blaming, or denying that violence even happened. Phrases like "I just snapped," or "I only just touched her," or "if you could only keep the kids quiet," or just "they're all lies," or "I blacked out, I was drunk, she didn't get the stuff for me." They're the sort of simple phrases that you can hear, but they have so much other meaning behind them around where especially responsibility sits for this guy. Who's taking responsibility for the behaviour, for the violent behaviour? Another thing you might hear is around mutualising the violence, meaning painting a picture of it's just the same. My violence towards her is the same violence as her towards mine. No, she's just as bad as me, or she gives as good as she gets. On one hand, research shows that violence, or family violence in intimate partner settings, a perpetrator uses that violence around power and control, and a victim survivor uses a resistive violence, defensive violence, to defend themselves against that power and control. But also a way to sort of counteract that kind of statement, such as she gives as good as she gets, is to actually explore, well, what does she get? What do you do? So it's not what she does, it's about what he does. And that's probably one of the key themes about working with perpetrators. It's about keeping the focus on them. Another thing you might hear is about pathologising the partner. She's got mental illness or an addiction. That's a huge problem for me. Or her father was violent, or her ex-partner was really violent, and trying to normalise her experience of being used to violence. Another trait is around being right all the time, a real strong righteousness. Very much cloaked in black and white thinking. Either things are good or bad, or right or wrong, or that kind of thing. Not much grey area or grey sort of room in that black and white thinking. Some kind of statement might be, I had to keep telling her that she was just plainly wrong. And so an argument was just based on perhaps me just telling her she's just wrong. So responsibility can really appear in different ways, in different statements. And I added the last one down there. Which says, I don't want to be like my father. And I thought I'd add that because it's true. I've heard that many times from men in these groups. But what it also says is they know what could be better. I've added there's a little bit of hope. It's not all negative. There are some statements we can latch on to say, well, actually, they do aspire to something better. They know it's wrong in some respects, but we can do something about it. So in general terms, men who attend men's behaviour change aren't there on their own volition most of the time. They're externally motivated from courts or what's called partner mandated, being told to go and get perhaps AOD treatment for alcohol, otherwise, our relationship's over. And that has them in a pre-contemplative sense, meaning, what's the problem? I can't see a problem. And so that's often the starting point with a lot of perpetrators. One size doesn't fit all. All come different. Come with their own presentations, which can either be aggressive, which can be quite worrying, and really feature with workplace violence or my own personal safety in a clinical setting. Or they can be compliant, meaning turning up on time, every time, all the time, answering the questions, being nice and pleasant. And then there's the charm, and then men being charming and even flattering. And these are strategies or ways that perpetrators have found to actually negotiate their relationships and to get what they want. So it can be disguised in a whole lot of ways. And probably aggression is easy to identify, and charm is something that we like to see and we like to experience, but it doesn't mean violence isn't present. So the summary of all of that is, from a narrative, from a perpetrator point of view, you can get insight into how they position responsibility, what their views around entitlement are, their own personal entitlement to resources, what their views about gender are, what their views about using violence. Violence is okay to be used from time to time. And then what their sense of male privilege is. And a real indicator around male privilege is when you do challenge it or do ask about it, it can generate an angry response. So some skills that I've come across that help with working with perpetrators is to be non-shaming and to be invitational and curious. It's really asking and exploring and unpacking and getting as much information out. And at the same time, listening for risk. Of those topics we've talked about in the parent control wheel, the new COVID strategies, of isolating partners, of other aspects, trying to listen for what that risk really means. And keeping the focus on the man's behaviour, not being deflected into focusing on perhaps his partner. There's a lot of sitting with uncertainty. We're just not sure about what's really going on. And the use of silence to promote conversation. And a lot of these are actually those micro counselling skills that we're all very good at and we use all day, every day with a lot of people. And so it's the same with the perpetrator. Use of here and now, to roll with resistance and picking your battles. They're all important things to be aware of in the moment to position yourself with your relationship, the therapeutic relationship with the client, as well as holding them to some account to what they're saying, to what their values are, and what the values are of the program that you're in. So things like role clarity and setting boundaries are important. What's the purpose of this session? What's my role as an AOD worker? And we can only work with the person who is present with us. We can't work on or change anybody else outside the counselling room. And one of the basics is, just respectful language. So having those boundaries can try and set limits as to the safety within the session. Also, what is my bias? Reflecting on what is my bias that I'm more prepared to go to than other topics. I guess my bias is around the gender nature of family violence, and you've probably heard in my language already. I've flipped between perpetrator and he. That is my go-to. It's something I'm aware of. It's something I reflect on. And the other way I think about that is I position safety of the partner is actually more important than other aspects. An area that's talked about a fair bit is collusion. I'd just sort of like to clarify in my mind what collusion is. I found this really nice set of statements from Motor Violence. And they've defined it as when a man's barriers to taking responsibility are reinforced. So I really like that word, reinforced. Reinforced either silently, by not challenging it in the clinical space. Could be consciously or unconsciously by me as a clinician. To say, yeah, you're right. All women are like that. By either nodding the head or by smiling at a veiled sexist joke, can all add to that reinforcement of gender inequality. And they'll reinforce violence supporting narrative as well. That it's okay to use violence on occasion, whereas there is no excuse for violence. And that statement can be really clear. If a program has that statement and supports that statement, being able to say that statement is actually really quite powerful. But ultimately, the collusion will really support or maintains the drivers of men's family violence. And I'll clarify them a little bit in the second half of the slide. And these are fleshed out by the Domestic Violence Resource Centre in Victoria. And they've described 4 drivers or gender drivers of violence. And the first one is condoning violence against women. Treat them mean, keep them keen. Just these throwaway lines that perpetrators can use just to elicit some kind of agreement or some kind of it's okay to think like that. Gender drivers are also or involve rigid gender roles and stereotypes. Things like boys will be boys and women are just like that. Again, trying to minimise the impact. Men's control of decision making and limiting women's opportunities. I earn the money, I make the decisions. Probably an older example than most is I remember my mum saying when she was young that her father told her she didn't have to go to school or do uni because she'll marry someone and she'll get looked after. That is that male's way of limiting opportunities. that example may be apparent now, maybe not so much, but that'll appear in different forms. And the last one is around male peer relations disrespecting women, using degrading jokes and locker room talk. And that's a way of men to actually bond together in reinforcing gender drivers. And I guess that really relates to that idea of toxic masculinity, where there is masculinity of being a man, but then there's this toxic nature to it as well, which involves gender inequality. So what are the responsibilities for workers in all of this? Marram, in its foundational knowledge guide, says professionals are not expected to become experts in relation to family violence, but everyone has a role. So it's not around really working with the violence, it's around working with the client around their use of violence. And if it's and is it giving them the results they're really after? As I mentioned, the narratives can really draw out the risk factors, and the common risk factors that you're going to hear from a perpetrator is you're not going to hear actual behaviours. You're not going to hear strangled, you're not going to hear a hitter, you're not going to hear a lot of the physical type of violence. You may on occasion, not often. What you will hear a lot about, though, are controlling behaviours. How the perpetrator expects and demands the partner obey his boundaries and his directives. Other situations are if the partner's planning to leave or there's a recent separation, that's a high risk time. Or whether she's pregnant or there's been a new birth. Has he got access to weapons? Does he love his guns and go hunting on the weekend and they're accessible in the shed? Has he threatened or attempted suicide, self-harm? That's a high risk factor for her getting hurt. And then obsessive or jealous behaviours towards the victim. And that can often occur after relationships have broken down and she might have repartnered. And other activities like stalking can come out as well. So what are the key responsibilities with family violence response in relation to Marram? Well, identifying risk. And identifying risk in victim survivor is well understood and well formed with a risk assessment, a risk assessment form. A risk assessment format for perpetrators is being worked on, due for release sometime this year. I go on. The second responsibilities are around assessment and management of that risk. The third are the newer areas of family violence information sharing, which really open the scope to being able to share information between organisations around family violence risk in order to maintain a couple of things. One is safety for victims, plus also visibility of perpetrators. The idea of secondary consult around family violence. We really like to promote that. And the consults you might have are towards myself or Sue, who are specialist family violence advisors, where our roles are located across the state in each of the catchments. In fact, your organisation's probably got access to one, if not, you're auspicing the particular role. Other areas you can go to for perpetrators is men's referral service. Now, they are aligned for men who want to seek to change their behaviour, but they're also great for secondary consult, and they can be done anonymously and de-identified. Or even the police with the family violence liaison officers when there's a real crisis emerging and you'd like to talk about a welfare check. And the last area is around collaborative practice, and it's around sharing family violence risk at a broader and higher level in the system, much like coordinated care is done with AOD care and treatment. This is really adding another layer of family violence care and safety. And the last area is around how we write up these things, case note and our documentation. And a key theme is to keep the perpetrator in view. So it's about writing about the behaviours that he used and the coercive behaviours that he used. And with the victim, it's about noting the impact of those behaviours on the victim. There's also tips around documenting efforts to protect and care for the children. Generally in our child protection services, it's the mother's responsibility. Mothers are given the key responsibility for safety, whereas it's the perpetrators ability to really do that. He should be really, well, they should be really held to account. And we can do so and describe that in our case notes really effectively. And also being mindful of if our language can be interpreted as victim blaming. She's staying in a relationship that she shouldn't be in. Well, actually, that could be reflective of she believes that's the best place for her to maintain safety for the kids. And the last area is around the intersectionality of a whole lot of other factors such as disability and ethnicity, mental wellness. They've all got a part to play in not so much of vulnerability, but how a person may be exploited or how their environment may impact them negatively by a perpetrator. There's further training in case notes, I noticed, by DVRCV as well, and that might become an issue too for clinicians in the future. That really finishes that really brief but dense area on perpetrators. So again, we'll just go to a quick breakout in pairs, where we're looking at how do you determine who is a victim, survivor or perpetrator. A client attends with limited information. How do we determine their status or if family violence is present?
Okay, we're all back. I think that the question that we had up is more of a reflective question and it's ongoing, and hopefully some of the information that we've given you today will help with working that out. But I'm just wondering if there's any standout things that people had in their pairs that they wanted to add in before we finish up. Someone? Because I think it can be a really...
something.
Thanks, Daniel.
Cracked under the pressure.
I do it every week anyway. Well, I was talking about how reflecting on what the role that fear plays in the dynamic between the partners is important.
Yeah.
Or especially with men who feel like they're being attacked and a victim, to talk about whether they're actually experiencing fear and whether they think that they've caused fear for their partner, because that can be the moment where people have a reflection about what the actual dynamic of power control is in the relationship. Yeah. It's a really great point, and also fear around children. The children may be fearful as well. So I think that's a great point. Great point, Daniel.
Because everyone's so talkative, I might just need to close this conversation up. I get it. It's awkward doing it in this space. I totally get it. So please take that as humorous, not as a dig. I would just like to thank both, before we wrap up, I'd just like to thank Steve. I can't even find my words. To thank Susan and Stephen for their contribution. As mentioned, both of them are specialist family violence advisors in the north and the west of Melbourne. So some of you may have come across them, but if not, you would have your own specialist family violence advisors in your regions, and a great source of information, secondary consult and support as well. So thank you so much, both of you, for taking part in this today. PowerPoints and recordings will be available very, very soon, and they'll all be up on our website, as with the other 4 recordings as well. So please make use of them as much as you need, and share them with your colleagues if you think it would be helpful. I think a lot of this is really, they spark a lot of conversation and spark a lot of thinking, and it's always helpful to be able to do that in a space where you can critically reflect with your peers and in supervision. So before we finish up though, we have one final poll to do. So I'll just pop that up now if people don't mind completing that. There's 2 questions, just as you would be familiar with, one around your confidence now, and also one question around what you found was most useful in this session.
And I'm just going to chat while they're doing that, Naomi. Is that okay?
Go.
I just wanted to add, I think there's other resources that have been developed by Mariah Ruth, who's been the VADA Family Violence Project lead. So we'll be adding that in as well, but just to thank you for her.
Yeah, great. Yep. Thanks, Sue. I forgot to mention that. So there you go, everybody. Again, feeling super confident, but still wanting to know a bit more and enjoying the content from the experts. Absolutely. So again, what would be super helpful, if there's anything in particular that you would like to share that you think you want to know more about, please let me know and we can look at developing some further programs. You will also have a survey monkey to fill out too about each of the sessions that you attended, again, just to get a bit more feedback about, you know, what you'd like more information about or what you found really helpful, and any other, you know, unsolicited kind of information you want to give to us, please do. I'm very receptive. We have a very robust feedback process. I actually want it and we'll use it. Yeah. So the more you can provide us, the better. But again, thanks to my colleague Jane for her assistance with this. Thanks again to Susan and George. Oh my God, I keep trying to say that. And Stephen. And I think I should stop talking because I'm not making any sense. And thank you all for your involvement as well. I hope you found these sessions.
Thanks, everyone.
Amazing. Thanks so much.
Thanks, everybody.
Thank you, everybody.
Thank you.